Hi, this is Walt Fritz from Foundations and Manual Therapy Seminars. I'm recording this video sequence today as a follow-up to a talk that I gave this past weekend at the third World Congress of Fascia. I was invited to participate in that online conference in a way that they were looking for my input on myofascial release, possibly how I teach it, how I believe it works, and allowing me even an entryway to present it from the context of the voice and swallowing work that I now teach. And I had a conversation with them via email, and I let them know that a lot has changed since entering the quote-unquote fascial field over the past 15 years, truly, and that I really no longer felt that fascia was quite as important as a lot of people do, as I was taught it was. I also shared my questions about, can we really know that it's fascia that's problematic and it's fascia that we're treating? And I proposed a title of a talk called "Seeing the Forest for the Trees," putting fascia in perspective when treating the whole person. And they said that sounded great. They wanted some balance in this fascia forward type of conference. So presented it the other day and just decided that I need to rework it just ever so slightly, so I can put it out there for everybody to see. I also realized that maybe a lot of what I'm talking about here today in this video applies not just to fascial narratives, but muscle narratives, trigger point narratives, joint subluxation narratives, pulled lymph narratives, weakness narratives, all of those concepts that, you know, we're kind of looking at the human, the patient, from this very, very narrow window, a silo of, you know, looking at them in a way where every problem becomes framed from our tissue of choice here. And, you know, to me it was fascia. I was taught that, well, the reason a person stands like that with poor posture, forward head, or pain, can't move, range of motion, everything was drawn back into, well, that's a problem of the person's connective tissue, the fascia. And then we were taught that narrative. We were taught to teach that narrative to patients and then to treat the fascia. But the same problem exists for therapists who say, no, it's that, you know, that particular one specific muscle that's having tension, that's tightness, that's in spasm, it's having all this dysfunction, and that somehow we can treat that individual muscle like it exists in isolation. So this talk has evolved from maybe it's not just about the fascia, maybe it's not just about any of these tissue-based narratives. When we're treating a person, I think it's important to treat that person and look at all the other possibilities out there of why dysfunction can happen and why our changes can be impactful for problems. So that's sort of the direction of where we're going. We're going to let this play out and see how everything goes. I don't know if many people watching this video are old enough to remember 60 Minutes back in the I guess it was probably the 70s and 80s and 90s, and at the end of every 60 Minutes episode on Sunday night, Andy Rooney came out. Andy Rooney was he was a curmudgeon. He was a kind of a grumpy guy that had some interesting ways to present the information. Some said abrasive, some said whiny, but, you know, recognize him as that curmudgeon who was sort of going against the cultural tides, etc. And in a way, when I was asked to do this talk, I kind of saw myself in that Andy Rooney light of being a bit of a curmudgeon, being a bit of a skeptic, of a cynic, and maybe a sense of offering perspective, offering another alternative. So I'm going to do my best Andy Rooney imitation here. Briefly, I don't want to belabor this too much because some of you watching these videos, my video here, already know some of my background. I'm a physical therapist since 1985. I graduated from physical therapy school, University of Buffalo, back before they even had created a master's in physical therapy. If you wanted a master's degree in 1985 and you were a physical therapist, you got it in something else, exercise science, business, whatever that might be. Late 80s, they expanded and advanced the career to a required master's level. And then, you know, within the 2000s, it's migrated and have evolved into a nearly mandatory doctor of physical therapy, at least here in the United States, where they're getting certainly a lot more exposure to evidence-based practice, to critical thinking, to really taking a hard look at the evidence for and against the various work that I as a physical therapist do, whether it's exercise or manual therapy, and questioning those mechanism of actions. And it's something that I wasn't exposed to in college. When I started my myofascial release training in the early 1990s, it was presented in a way where evidence didn't matter. It was our experience that mattered. It was patient satisfaction that mattered. And yeah, those things do matter. My patients should be satisfied. My patients should feel like the work that I'm doing is helping. But that's often a very loaded concept, and it's easy to create the sense of meaning and value from an intervention. And that's what I saw as happening with the myofascial release training that I received back then. And you know, it worked well. I really enjoyed that work. I worked through that model in the 1990s, and you know, progressed my way through classes and working my way up to advanced level classes, and ended up working for a particular continuing ed provider as a teaching assistant, and kind of knew the ropes well. I questioned a lot of things about that narrative along the way, like hopefully we all do, but I knew when to keep my mouth shut, and I did keep my mouth shut. I kept my mouth shut until 2006, when I parted ways with that myofascial release community, that tribe, the tribal mentality that's often associated with myofascial release, craniosacral therapy, neuromuscular. You know, you fill in the blank of all these different intervention modalities that we learn, and each one sort of has this tribal type of a following. And I was part of the tribe, and I accepted that and enjoyed it. But after I left that tribe, I started exploring other narratives, other explanations. How are people out there doing work like I am as a physical therapist with a primarily manual therapy practice? How are they doing work? How are they viewing dysfunction? And how are they viewing the mechanism that you're creating a change for that dysfunction? And that's where things got really, really dicey, because, you know, when I was inside that silo of myofascial release, you didn't see any of this dissonance happening. All these people doing all these different things and describing in different ways and having almost basically the same effects. That should be troubling to clinicians, but I don't know, maybe we just put the blinders on, so we really don't have to be exposed to that. And I think educators also try and keep us away from those sorts of windows. Don't look out that window to see what others are doing, because they're not doing the right thing. They're not doing it the way we do it. And some of this may be a foreign concept to you, but in my MFR background, that's kind of how things were presented. So, excuse me, in the early or the mid-2000s, I started a journey of exploration, of evolution, trying to understand why is it that when someone does with their hands an identical thing that I do, but they describe it differently, how does that work? Diane Jacobs, a Canadian physiotherapist, was one of those people who opened my eyes to not alternative, but alternate explanations. And I took some coursework from Diane, and Diane has been very, very giving in terms of generosity of helping me understand things from different perspectives. And that was really useful, because Diane explains things from a nervous system perspective, that when we touch somebody, that we're engaging the nervous system, cutaneous nerves, lots of other things that are embedded in her really fine work. And I learned a lot from Diane. I remember sitting in her lecture when I took the class well over a decade now ago from her, and just watching her work, and then rewinding the tape to how I learned myofascial release. And it was really fascinating, because here was Diane doing with her hands and her arms and her body things that I was taught in myofascial release to do, right? The standard, well, we called it a cross-handed release, and Diane called it different things, but like a lot of people do. But why is it that something was said that when we do this and stretch, we're engaging fascia, whereas when Diane did it and stretched, she was talking about engaging mechanoreceptors, engaging cutaneous nerves that feed into the central nerves right to the brain. I guess it was a realization from Diane, from my myofascial release background, craniosacral background, and all the other stuff that I learned, that, you know what, people are doing their best to come up with an explanation to explain why is it that people are have problems, why is it that people are helped by what we do. And there was an understanding that truly nobody has all the answers, myself included. And what I strived to from that point on with Diane was not to get completely enmeshed and entwined with one model, with one tissue, with one narrative as being the most accurate or the most effective, but understanding that there's a lot of different factors at play here. What are the common denominators when I did my myofascial release work, thinking I was working with fascia, when Diane does her dermal neuromodulation work, believing that she's engaged in the nervous system? What are the common denominators? That's what this talk is about. That's where my evolution has led me over the last 10 years. The common denominators of the therapeutic relationship, the common denominators of human interaction, of empathy, of active listening, so many different things. Shared decision making has become one of the biggest and loudest drums that I beat when it comes to both treating as well as teaching. Shared decision making is something we're going to touch on in this workshop, or in this lecture, as well as a lot of other things. So let's just see what else. I'm working my way down my list here, and some of you might be familiar with my infamous unraveling on the somasimple.com website. SomaSimple, back in the early and mid and 2000s, was a forum-based website. It's still there, but a lot less active. That was basically dedicated to explaining therapeutic effects from a neurological perspective. And back in 2005, SomaSimple was doing what they were terming a deconstruction of myofascial release. Deconstruction to them was basically really assessing what is it that's being said and is it accurate. And I interpreted that word deconstruction in a very different way. I saw it as a personal attack, as a professional attack on myself, as well as my tribe, the leader of my tribe, etc. And I went on SomaSimple to defend my turf, defend myself, defend my mentor, etc. And what happened on SomaSimple was basically an argument that went on for about 6 months, where each side presented what supposedly evidence, supposedly data, supposedly perspectives and philosophies on manual therapy, on how the body works and doesn't work. But what I recognized in hindsight, looking back, was what I was presented with by 5 or 6 key individuals on that forum. I was being presented with perspectives on explaining human function as well as therapeutic actions that completely were disconnected from the way I had learned things. I was being presented with neurological explanations, and my brain was still thinking in fascial narratives. So I basically regurgitated all those references that I had been given and were told that describe why myofascial release works. And basically nobody read each other's stuff because everybody thought each other's stuff was crap. I did. I thought their stuff was crap. But basically, I learned nothing from that engagement, and they learned nothing probably except that I was incapable of critical thinking, at least from their perspective. I got kicked off that forum site numerous times during that 6-month argument for bad behavior, for ad hominem attacks and things like that, that I really didn't understand what that was at the time. And then they let me back on after I promised good behavior that I, of course, couldn't keep. And, you know, the cycle just repeated itself. And I equate the whole 6 months as sort of a constantly flushing toilet of just, you know, this chaos of things going around and nothing really being established at all. They finally closed the thread, and it wasn't long after that. By the way, if you're interested in that, somasimple.com, you can find the conversation. It's called Myofascial Release, the Great Conversation. It's right there up on the homepage. Unfortunately, what never made it to the homepage was something that I started, another thread that I started on there about a year or two later after I had transitioned away, evolved beyond the myofascial release world, and kind of came back to say, I'm sorry for my actions. I'm sorry for not listening, but I'm here to listen now. From that point on, that really was an eye-opener for me. That's where I met and became engaged, engaged with Diane Jacobs, who helped me through this process, as well as a lot of other people who showed me that everybody's got different ideas on why therapeutic processes work, and maybe it doesn't have to be just one story. Maybe it is about that collection of stories, looking at it from certainly the physical perspectives of the neurobiologic, the neurophysiologic, the biomechanical, the whole thing, but also bringing in behavioral sciences, bringing in all of these other ancillary type viewpoints that I don't know that therapists really get enough of. I don't know whether I got enough of that to say that, oh yeah, I understand that when I create a meaningful, respectful relationship with someone who's coming to me for help, that relationship, that we build and foster in and of itself is capable of potentially some of the outcomes we see. In being asked to present that talk to the Third World Congress of Fascia, I really had some time to reflect too on the tone of my presentation. I do realize that sometimes when I get on my anti-MFR bandwagon and start really beating that drum, that it can sound really confrontational. I can sound confrontational in terms of doubting another person's perspective. And I think that, well, first of all, you never win any fans that way. It tends to be something that you just, separate yourself from others. And that's something that I really strove not to do. And as well as to hear with how I'm presenting this, I don't mean to demean fascial science, to fascial perspective, or muscle-based perspectives, or any perspective at all. The thing that I encouraged myself to do, and I might encourage who's ever watching this, is at least allow it to be tempered. You know, your background might be in fascia work, in fascial science, believing that the problem is fascia, that we can influence fascia in a singular way, but understand that there's always more than one explanation. And you know, that when I'm teaching this work to clinicians who might have a fascial background or a muscle-based background, you know, if we talk about, for instance, when it comes to muscle tension dysphonia, it's often viewed as too much perilaryngeal tension in the inferior constrictor musculature, etc. And the old model was, well, you identify it through elevation of the larynx, through auditory cues, but then you palpate to feel for laryngeal tension, and it's like, okay, I found the problem. And then you reach in there and you start manipulating that muscle tension with the view that we're breaking up that tension, and we might be. I mean, it's a hard one to say, no, that's not happening. But I remind people that there's ways that people can improve, and whether that's a voice disorder, a range of motion of the shoulder disorder, pain disorder, right? That's not simply manual therapy oriented. Sometimes it's exercise oriented. Sometimes it's movement based orientation. Sometimes there's more of an educational basis to it. You know, if you do things in different ways, if you modify, for instance, your posture or your movement patterns or a lot of other variables that don't involve touch, we can often get people to have an improved quality of life. I mean, that's a given. So the way I equate to or sort of relate to this is, while we might be breaking up tension here locally, we might be releasing a fascial restriction locally here, or affecting a single muscle that's too short, or whatever your story is. But as soon as we touch, as soon as we engage, both conversationally as well as therapeutically with a therapeutic relationship, as soon as I do something with that person, my patient, and they sense the touch, sense the involvement, sense the engagement, sense my interest in helping them, all those 3 or 4 factors that I just mentioned right there, those can be part of why a person improves beyond right here, what we think we're breaking up. And even if we want to look at it as a 50-50 split between, okay, maybe I'm breaking up excessive fascial restriction or muscle tension, but as I poke here and as I validate my patient's experience, like, oh, you mean that right there? And they say, yeah, that's right, that's it right there. There's a lot of things that happen from peripheral to central, from bottom to top, and then that can then occur from top back out to the periphery. That could be a significant reason why that therapeutic interaction had value. And that's the one thing I ask my learners when I teach this work to remember. And I might ask you as well. I'm not going to ever get anybody else to step back from their full beliefs, because I've not lived their life. I've only lived mine. But what I would ask you to do is at least see that there's other ways to explain this. And I think sometimes people feel like, well, that uncertainty of not knowing makes me seem like I don't know. And I can certainly understand that. But personally, I think the more that we learn, the more perspectives we're exposed to, the more we understand that it may not be possible to ever know why someone is having a problem, and to know why the therapeutic interaction that we have with someone has an effect. I love telling patients, and I mean this from the bottom of my heart, I may help you, but I might never know what was wrong with you. And at first it seems like a little, wow, this guy doesn't have much experience. This guy doesn't know what he's talking about. But most patients, after a while, when they really think about that, and we talk about all the different stories they've heard, and they realize that, you know what, nobody's got the answers on what the story is. So let's just try and do some things here that feel helpful to you, which is why I've gone away from saying, okay, it's all about my skill finding your problem. And now it's about our skill together, understanding, is what I'm doing right here, right now in this area with you. Whether I do soft tissue manipulation concepts, whether I do that myofascial release perspective, whether I do traditional stretching or exercise or cognitive behavioral work. Is there anything about what we're doing right now that feels like it could be helpful? And if so, let's continue. And if not, help me help you to get to something that you can relate to and can feel helpful. I know there's a lot of different fascial approaches and myofascial release, myofascial induction, trigger point work, so many different sort of brands and then sub-brands out there. I can't necessarily speak to all of those because I did all of my training under one myofascial release model. It was a model that was very prescriptive in terms of how touch must be applied. It had to be directly on skin because if we're working through clothing, then we're releasing clothing and not fascia. Now think about that for a second. If we're not on somebody's skin, we're working over clothing, we're releasing their clothing and not their fascia. Now, I didn't have the chops of critical thinking to really question the source back then, and even if I had questioned the source, I might have gotten booted from the club. But to say, wait a minute, I can see if you were saying if we're not on skin, we're releasing clothing and not skin, but that leap into the body, that leap into the darkness of the depths of anatomy and physiology, to say that, well, I can contact your fascia here, I can feel what's wrong with it, and I can treat it from out here through this big, thick skin suit. It was something that should have been a red flag for me back then when I heard some of those stereotypical type responses on how touch must be applied. But if it did sink in, I just let it go. I knew that it wasn't in my best interest to voice my concerns. But then, you know, I think of some of the other things that happen here too when we make certain claims about impacting structure, right? Can we know with certainty that it is a muscle that's at fault? And it's the muscle that we're impacting, without the understanding that even, okay, it is a muscle in spasm right here, or in tension. But why? Why? Is it the muscle deciding it's having a bad day? Or is it potentially the nervous system that's feeding that muscle? Is it autonomics in terms of a heightened fight or flight? Is it countless other factors, right? Are we really able to isolate a tissue and treat it, except for the skin? I mean, that's probably the most obvious one that we can, but everything else is basically guesswork. We might be making those sorts of leaps into the body, but I think we need to acknowledge that you've got a lot of other systems at play here. One of the things that bothered me too was the specificity of touch that was mandatory in myofascial release that I learned it. That if you're not holding a sustained stretch, right? A sustained stretch to where you engage, air quotes, the fascia, and you hold it up under tension and holding it for the requisite time period, then you're never completely and adequately releasing those fascial restrictions. Now, I learned it, I followed it, I used it, and it worked. So there was my proof right there. But what I found interesting was that when I started this work back in 1992, the time rules were you need to spend 90 to 120 seconds engaged in fascial engagement in order for the fascial release. And if you don't hold it that long, it's not going to properly release. But then somewhere in the 2000s, they modified that rule to be a 5-minute rule, where if you're not holding it for 5 minutes, then the principles of mechanotransduction don't come in. I was like, wait a minute, what happened in 1992 when I learned this, when we were working under a different perspective? it's not that we can't evolve understanding, but we were getting those results at 90 to 120 seconds. And now you're telling me I have to wait 5 minutes to get those results. So I don't even want to get into a debate with full-fledged supporters of that model, because we all come at it with blinders, myself included. But does the specificity of touch matter? Does the time frame matter? Does the style of touch matter? There are some models of myofascial release and Rolfing, etc., which are exceedingly assertive. Some might say aggressive, right? We come in here with a pretty aggressive stroke. That's how I was taught not to do it. You're forcing a system then. You need to come in with a slower, prolonged stretch. And you know, there's two camps and they're sort of in opposition. Some of them are doing this work and others are doing that work. The weird thing is, and I thought this was weird back then, but I didn't dare, voice this at all. But both of those schools, both of those models are reaching into previous evidence, previous explanations to validate why their work works, why their beliefs are the right ones. Isn't that a problem? Isn't that a problem when people are taking evidence and saying, here's proof of why our work works, when they're doing something really quite different with their hands? Are we really creating the changes that we think we're creating? And that's one of my big points right here, right? And how do we decide what sort of touch to do? Well, most people decide because that's how you were told to do it. That's how you're taught to do it. So then you apply it, you see outcomes that are positive, and when we therefore post hoc fallacy assume that the touch must have been correct. But I now think that it's not a lot less important how I touch somebody, the fact that I'm touching them, right? That things like the concept of touch-based cueing is one where, let me give you an example. A person might be having neck pain or poor voice, poor swallowing, that sort of thing. And you look at their posture and you see this, all right? The classic forward head. All different people talking about why it's important not to have a forward head for performance, for cosmetic, all those sorts of things, right? So as a physical therapist doing manual therapy, I might take that person with a forward head and I might put some input here and gently press backward to engage the tension within the muscles, within the fascial system, within the nervous system, whatever that might be. And from a tissue-based perspective, my brain is thinking, oh, okay, we're stretching, we're releasing, we're creating impact because I'm holding it for the requisite period of time. And you know what? Sometimes people come out of that interaction and say, wow, my head is in better alignment and I can move with less pain, sing with less problems, swallow with less fear. So we said, boom, there it is. That's why you need to hold a long stretch. But then in comes someone who does a different kind of touch. And it might even be a non-licensed health professional, vocal coach, for instance. And they might come in and do touch-based cueing. Touch-based cueing could be something like this. They see the forward head and they come in and they say, get your chin back. And they give that little touch to cue the person, to cue their awareness, their brain, their central nervous system, etc., to say, okay, get it back like that. There's no prolonged input. There's very little thought on the part of the clinician that they're changing something locally at the tissue level that's in distress, that's too tight, that's too weak, all those sorts of things. From the perspective of the vocal coach, they might be simply saying, get your head back as a cognitive cue. And those two seem incredibly different, right? The effects of prolonged stretching with the belief that we're accessing what's wrong with the tissue versus that touch-based cueing where we're accessing this up here in the patient. And from the old models, they are very distinct. But when you start taking a look at some of the evidence that's out there for why manual therapy is impactful beyond tissue-based narratives, I think there's a lot less room between that prolonged sorts of touch or that sense of tissue-based effect that we're having and the effects of touch-based cueing. In fact, so little space that they may be the same thing. We're just choosing different ways to apply work, and we're choosing different ways to see if the patient reacts and responds to a positive way to those touches. I was encouraged when I took a look at the list of educators, list of people who were going to be presenting at this online third World Congress of Fascia, and saw a few what I think are more friendly faces, at least to my blended narrative perspective. Joel Bialowski, physical therapist, PhD, who I quote his papers in my book, in my workshops to my patients. Joel talks a lot about the multifactorial influence that manual therapy can have, which really moves beyond there's something right here in your tissue that's a problem, and there's something that happens right here locally when we do this to break it up. And those are variations on that story. It's basically what our industries are formed on. It's about fascial fairy tales. It's about muscle stories, about all these other things. And you know what? They all work, but why? And Joel Bialowski is one of the people who are taking a look at that. Jerry, Geri, is another person who I quote quite frequently in my classes, who talks about that, you know what, touch is simply another form of communicating without words to the patient's brain, instead of those local effects that we think we've had. By the way, all of these references are in a linked handout that I have on my website from this talk that I gave here, as well as the one I gave to the Fascial Congress. There's a lovely paper by Kolb, Kolb, in 2020, who wrote a paper regarding, we know so much about how manual therapy works and doesn't work. What are we waiting for? In terms of education, manual therapy educators, what are you waiting for? Instead of continuing to insist, it's all about that tissue. It's all about that pathology. And then you build the story around that pathology, around your favorite tissue, to make yourself sound credible. But you know what? There's just too many stories for each of us to be totally accurate. The more I learn, the less of which I'm certain. And that's certainly how this talk came about and where we're going to go here. So a colleague of mine on social media, as well as someone I've met a few times in person, Ray Allen, wrote something one time online that I wrote down and I never forget. And it's a variation on the concept: we treat people and not tissues. We treat another human being, and we don't treat the individual tissue that's in distress, even though that's how it's presented. And that's what I try and keep in my mind, is I'm working with a human being here. I'm not working with a fascial problem. And my goal here is, in this brief talk, is to highlight some of what others are using to explain why we get effects with manual therapy, whether it's myofascial release or massage or manual circumlaryngeal work or trigger point or neuromuscular, fill in the blank. Why might we be getting impact beyond those tissue-based stories? Of actions are probably one of the most least understood concepts of manual therapy. Mechanism of action studies are really well done ones, all right? Really actually quite rare, I'll call it. Outcome-based studies are really quite common. You know, I'm going to use one, for instance, in a myofascial release study for, I don't know, pick something, right? Jaw tension. And you know, in the beginning of the paper, they talk about the jaw. They talk about the prevalence of TMJ disorder. They talk about the problem of fascia becoming restricted or scarred or bound down. And you know, there's a reference, one of those little bullet points or you know, numbers that lead you down in the reference list to say somebody else in the past has written a paper about that. That somehow gets them past the need to actually explain, is that actually accurate, or is it simply another one of these either theories or you know, kind of made up stories? And then they go along and they test something and they say, okay, with this we're going to do, you know, maybe a control as well as a test, and you know, might be a decently done study to show that when we do certain things in the region of the jaw, it helps with a person's pain, mouth opening, clicking, whatever that might be. But that outcome doesn't prove what was stated in the mechanism of action, that brief little piece in the beginning of that outcome-based study. It simply says when we did something with our hands, in the area that a person was having pain or limited function, it shows that that was helpful, not that it proved that myofascial release was the answer. Mechanism of action studies are exceedingly rare, and I consider Bialowski's paper one plausible mechanism of action paper out there. A lot of good ones of those, but you really gotta dig deep to find them. You know, there was a discussion a year or two back that I was having on a Facebook group, a private group that I belong to, and people were sort of bouncing around an idea. The idea being, If you were asked to produce a paper, produce a book, if you will, that best explains your views on why people have problems and why your therapeutic clinical interaction has effect, what paper would that be? And it really got me thinking, because, you know, in my mind, I'm picturing all these different papers that people are going to post depending on how they were trained and how they, you know, experience life, etc. But I realized that there was one paper that really stood out to me. It was a paper I came across when I was working on my book. And it was a paper that's actually older than me. It's a paper written in 1957. And it was written not by somebody in my profession or shared professions of physical therapist, etc. It was written by a psychotherapist, Carl Rogers. And Carl Rogers wrote a paper in 1957 that challenged the prevailing belief narrative, which is not that unlike that's been in the therapeutic narratives for the last 20, 30, 40 years, in that at least some people believe that it's the modality that's most instrumental in creating change. It was taught to me that's the fascial problem and the fascial solution that is why people improve. But then next door in a classroom next to mine, someone is teaching about, you know, muscle tension. Someone is teaching about trigger points. Somebody's teaching about nerve tunnel syndrome. Somebody's teaching about, you know, inhibited glutes, and they're all getting effect. And what Carl Rogers wrote in this paper, which basically got him ostracized from his profession, at least in theory, because the prevailing thought in psychotherapy in 1957 was that the modality was the reason that people benefited from psychotherapy. Well, Carl Rogers put forth what it was not the modality, it was the relationship that we build. The relationship that he builds with his patients, with his clients, was more instrumental in the model, in the modality, and the techniques that he used. And there was something about that paper that really struck me, because it really kind of runs into full force what we're talking about here. People make all kind of claims about a modality and about the tissue-based problems, but yet they all work. I keep repeating that. Why is it they all work? Well, it could be based on Rogers' principles that it's about the relationship that we build with our patients that might be one of the more influential pieces of why we help people. That paper, or the concepts behind that paper, have been just constantly updated and evolved. There's a more recent paper by Miciak, M-I-C-I-A-K, that's in that reference section that talks about therapeutic alliance, which those words did not make it in Carl Rogers' paper, but therapeutic alliance is basically what Miciak is reframing that from a current day model of, in Miciak's case, physical therapy. But it truly, that's a big player in this, is being on board with each other, patient, therapist. That's a huge part of why our work could be impactful. Neurodynamic effects is another interesting concept which I knew nothing about during my earlier phase in a physical therapist. I didn't learn it in school because it was a little before neurodynamic technique came out in the early 90s. And it certainly wasn't exposed to it in any of my MFR training because, you know what, it didn't quite resonate with that model. It was a very different one and sort of like talked different principles, etc. But, some of the early work by David Butler and Michael Shacklock has evolved greatly into understanding the potentials of why pain might be there, dysfunction could be there, and how remediation of it can occur. Early on in the neurodynamic papers, it was a very precise, almost a tissue-based model where the nerve exists within, yes, a connective tissue tunnel, and much like a sleeve on a sweater, if that sleeve is too tight, it really restricts you from reaching out and gives you that feeling of compression, of claustrophobia to me. And it was early on thought that when we identify that nerve through specific testing, we basically elongate the tunnel and the nerve to its length, and then we do some what's called flossing or nerve glides that we're mechanically freeing that nerve up within its tunnel. And like all good scientific explanations and theories. They undergo sort of some vetting and some reworking, and those stories are now a lot more nuanced and a lot more multifactorial and include a lot of factors beyond that pure mechanical action of trying to free up that nerve within the tunnel. But yet neurodynamic technique is certainly a concept that we have to pay attention to. Diane Jacobs introduced me to neurodynamics through her cutaneous concepts, and she got some really brilliant, simple models to explain why is it that when we touch somebody right here at their skin, might that be enough? Do we have to tell stories about the deeper tissues? We can never say that those stories aren't accurate, but if we could layer plausibility into that, there's a concept being, we might never be right, but can we be less wrong? And I love that concept. And inclusion of neurodynamic technique is part of understanding how to be less wrong, understanding therapeutic relationships. The therapeutic alliance is another way to learn more about it and understand there's so much more happening besides what we believe we're doing to the tissues at that level. There was something brought up in Robert Schlepp's 2003 paper, the fascial plasticity, a new neurobiological explanation. In 2003, Schlepp wrote that paper, and really was, even back then, 20 years ago, was looking at the neurobiology of fascial plasticity. Now, a lot of that has evolved. A lot of that hasn't been proven yet. But there was one small little point in that paper that really made me understand how tribal relationships can affect us, right? Because in the paper, and I think it was in part 1, Schlepp had to pull out basically a chart of basically receptors, mechanoreceptors, nerve endings, and their potential influence on when we do fascial work, and we engage one of those nerve endings, how that could be part of the reason why things change. And I think back at the time, Schlepp was relating that to fascial plasticity, the thought that fascia is reformable, remoldable, and I do think he's sort of backtracked on that concept since that in some newer papers. But he talked about Ruffini receptors, Ruffini nerve endings, Ruffini mechanoreceptors, and these type 2 receptors, essentially they're very specific. They respond to a lateral input, a lateral stretch input. And in Schlepp's paper, he talks about the location of those, talks about it within the connective tissue, with joints and things like that. And he mentions that those can be part of the whole dynamic, as well as a nice little side note that he put in there that Ruffini mechanoreceptors are said to have a secondary response, that when you stimulate them through a lateral stretch, to reduce sympathetic dominance. Now, there's an interesting one that we don't often get called on. Like, is it the fact that our gentle, sustained touch is selecting Ruffini's, or is selected by Ruffini's to send that message to the brain, the autonomics, and reduce the sympathetic response? It's possible, right? But what I noticed in Schlepp's paper is he talked about the placement of those Ruffini's that sort of biases towards the fascial approach. And what I learned in Diane Jacobs' class is, okay, they are deeper in the connective tissue, etc., but they're also richly embedded in the skin. It's actually seemed to gloss over that. I don't want to say he purposely ignored it, because I don't think there was any malice intended. I think it was just we're staying with our tribe. He's describing something from the tribal narrative of fascia that, look, there's these receptors that could be really significant in terms of why people change with fascia work. But what Diane Jacobs is saying is, yeah, but they're in skin too. And maybe it's not about fascial work. Maybe it's about sustained input. And whether it's skin or deeper, that sustained input is sufficient to stimulate Ruffini's and have a possible cascade effect. That was, to me, just kind of symbolic of what happens within tribal mentalities and how we definitely we speak tribe speak, because that's what we're expected to teach. It's in practice. I'm guilty of taking some of what I learned in my myofascial release and some of the other early trainings, and sort of really deconstructing those, and some might say directly criticizing the message as well as the messenger. And you're free to make your own decisions on what I'm trying to do here. What I'm trying to do for myself is to unpack what I was taught and what's currently known. And is what I was taught plausible through critical thinking when it comes to a science-based approach? And I'm going to apply the same filter to some of the newer information too. Not everything has, that randomized control study type of validity to it. Some of it is case study based. Some of it is anecdotal. We don't need to completely exclude anecdotes and personal experiences, but we have to realize that our lived experience is not data. It's not fact. It's fact for us. There was a concept in myofascial release, like a lot of manual therapies, that required continuous touch. Now, in fascial work, continuous touch was said to be continuous engagement of the fascial barrier, air quotes around that barrier, right? The place where when we engage the fascia and we work to engage one layer against another, and we hit a stopping point, that was viewed as the fascial barrier, where there was a restriction keeping those layers from sliding. And we were told you need to stay engaged with continuous touch and continuous pressure at that barrier in order to get it to, air quote, release. I told you earlier, the problem there is earlier it was 90 to 120 seconds we should wait, but then that changed to 5 minutes. I'm wondering if that particular time isn't quite as important as I was taught. There's a paper that I came on within the last 3 or 4 years, written by a researcher, lead researcher by the last name of Serratelli. Paper's published in 2017, and it's titled "The Effective Continuous Touch on Brain Functional Connectivity is Modified by the Operator's Tactile Attention." Now, if you didn't get that whole title, don't worry about it. Serratelli, it's in the references. But picture this for a moment. What they were trying to do was, well, first of all, they understood that that certain styles of touch, some of which are the kind of touch we're talking about here in quote-unquote fascial work, has preferential input to C-tactile afferents, cutaneous peripheral fibers that are preferential for interoceptive centers. Interoception is basically a human being's ability to self-regulate. And really interesting work around interoception. Some of the papers were done, McParlin in 2022, were done looking at mother-infant touch and how that touch is actually helpful for allowing the baby to evolve and mature and self-regulate. They're seeing that, though, now as having sort of a broader context, the type of touch that stimulates interoceptive centers, as well as how it affects the whole human. But Serratelli was acknowledging that we know about touch having interoceptive properties, but what Serratelli wanted to know, well, what about the attention from basically the clinician? When I'm working with someone, does my attention matter when it comes to touch? Me being focused and present and grounded and there for my patient, people phrase those in different ways. Did it matter, or is it okay if I'm, basically listening to music through my Bluetooth earphones, or mentally somewhere else, figuring out I got to do my errands after work? So what they did was they did an interesting study where they basically, I think they had 40 subjects, and they wired all the subjects. So basically the wiring of the head was able to detect what parts of the brain were active in that person. And then they laid them on a massage table. I believe, if I remember properly, there was a visual field, so the patient laying on the table could not see the clinician standing down at the feet. Okay, so that was sort of the basic setup. There were two variables here. One of the variables was the clinician was wearing headphones. The clinician's headphones were being blasted with loud random noises under the assumption that loud random noise would keep the clinician from being able to attend to their task, and their task was to hold on to the ankle bones. Not to do anything, but just to hold the ankle bones with continuous touch. And I don't quite remember the wording, but the paper's available to you if you want it, or I can send it to you. Basically, they were just told to be mindful, be present, apply your focused touch to that person's ankle. So that was group one. The clinician was thought to struggle with paying attention. In the other group, there were no headphones, there was no random noise. The clinician was just able to stand there, hold the ankle, And I guess I jokingly say, think loving thoughts at that ankle. Okay, so what they were doing, you got the two scenarios, right? They were testing both. And then, but what they were watching was they were watching the meters, the recordings, to see what was happening up here. And with the, in the test cases where the clinician was being bombarded with noises, very little changed in the patient's activation patterns of the brain, the attentive centers of the brain. No matter how long they watched it, not much changed. But in the other one, where the clinician was able to attend, what they saw was, I'm gonna sort of paraphrase this wildly, was basically an opening up, an activation of those attentive centers of the brain. The longer the touch stayed in place, the more the patient was responding to the clinician's touch. Now, I cherry-picked the study because a lot of times I hold a technique for what some clinicians view as very long periods of time. Some might say ridiculous time periods. I might, if we're having an effect that my patient feels is helpful and fruitful and wants me to continue, I might hold a stretch for 5, 10, 15 minutes. Not without me taking a break, not without giving them a break, but it could be a significant length of time. And what Serratelli found was 15 minutes was where activation levels peaked. Continuous touch for 15 minutes caused the greatest amount of brain activity in terms of moving toward the directions we want them to move when we're doing therapeutic interactions. And after that, the gates sort of slowly closed again. Now, what Serratelli's study does not show or prove is that my longer touch, my continuous touch for long periods of time, is more effective than your maybe massage-like touch or trigger point touch. What it may indicate is it could be differently effective. It could tap into different parts of the human being that we're working with, and not just that peripheral tissue we think we're focusing on, but that whole top-down, bottom-up piece of the patient. And it also shows me that while I'm human and I still think of, oh, what am I going to make for dinner? What do I got to stop at the store for? All those things. Trying to bring myself back, trying to be focused, present, grounded, all those things. Because at least by this study, it does matter. And I think those are important things to know about. I talked before about Joe Bialowski. His papers are referenced in the references from this little talk here. He, back, I think 2009 and 2018, wrote 2 papers, and one builds upon the other. Geri, G-E-R-I, Manual Therapy, Exploiting the Role of Human Touch. Here's that quote that I have at the top of my Facebook page. Clinicians should remember that manual techniques are not tools to fix a patient's body. Rather, they provide the opportunity to communicate to the patient, with the patient's brain, similar to words. And to me, that is an embodiment of our work, even though we think we're fixing things in the periphery, in their tissues. We sort of view ourselves as sort of this expert body mechanic. And okay, we learn these things. We get skill, we get a reputation. But as Geri is talking about in this paper, our touch has so much more effect than just what's happening peripherally. And Geri's touch paper is a relatively short one, easy one for you to get through if you're interested. I mentioned Kolb earlier, the evolution of manual therapy education. What are we waiting for? Contextual factors. They all talk about contextual factors, those surrounding factors that also influence our ability to help somebody. Contextual factors and placebos, sometimes they overlap a bit, or the way people describe them overlap. Someone comes to you as an expert. They've been referred by someone who they trust. Could be their physician. It could be a friend or a relative. It could be your Facebook page, your website, talking about you as the expert, talking about a problem in a way that resonates with someone. They come to and they knock on our door. They come to see us. Part of that, seeing us as an expert, hoping that we're the expert that helps them, that's part of that placebo effect. That's part of the contextual factors. And I do know that some people misunderstand what a placebo is and get defensive when it's mentioned, because they think they're saying, no, it's not about, they think it's about trickery. We're not tricking anybody. The placebo effect is nothing at all about that. It's about understanding that everything surrounding the clinical encounter has potential to influence. And the more you understand it, the more you might be able to help. I would recommend my good friend Brian Fulton, who's a Ontario-based RMT who wrote a book called The Placebo Effect in Manual Therapy. It's available on Amazon, and Brian is just, the book is great. It talks about so many different factors of understanding placebo and nocebo, and also in some ways how to leverage it, all right? And I'd recommend Brian's book to anybody. Historically, let me just go into my now more niche interest, and that's working with voice and swallowing disorders using manual therapy. Historically, manual therapy was introduced to the speech pathology community in 1980. Some would state 1990, but Arnold Aronson, MD, wrote a book called, excuse me, Clinical Voice Disorders. First edition was in 1980, then 85. Third edition, 1990, was the one that seems to be quoted most in a lot of ENT and SLP literature when it comes to manual circumlaryngeal treatment, laryngeal manipulation. But if you really trace back, the 1980 book text basically is the same as the 1990 when it comes to this section, all right? And what Aronson found back then was when someone has vocal hoarseness, a voice disorder, that it's often, he speculated, due to too much laryngeal tension, muscle tension surrounding the larynx and the hyoid. And there was it was a fairly short passage in his book, maybe 2 pages or so. And they basically talked about how to palpate to find it, how to then manipulate the larynx with the thought that when we manipulate it, it's that movement, rather assertive or aggressive. It's aggressive in my eyes when I receive it. I'm not fond of it. But that somehow we're changing that laryngeal muscle tension locally. And then they also do something called reposturing. Well, they'll lower the larynx, viewing that as having a lasting effect. And then they'll begin something called tapering, which they then ask the patient to come in and start voicing. But basically in 1980, Aronson was presenting a model, which I call the what happens in Vegas stays in Vegas perspective, right? That somehow the problem is right here in these muscles, and somehow the intervention has its effect right there, which does not sound that dissimilar to most of the manual therapy models out there. We do joint manipulation because the joint is too snug, tight, whatever that is, and we see the effect of it being right there at the joint, right there at the fascia, right there at the muscle, right there at the trigger point, right there at the lymph ducts, right there at the tissue where we think the problem lies. And, you know, just like in the manual therapy, the more general manual therapy world that many of you belong to, if you've been reading and staying up to date with any of the newer research, you're seeing an evolution of those concepts, of those terms, that it's not just about the problem here and the solution here, but it's multifactorial. To the point where in 2019, Nelson Roy from the University of Utah did a paper where they were looking at muscle tension dysphonia, vocal hoarseness. And it was a case study, but it was a unique case study in that what they did was they had a patient with muscle tension dysphonia, and they had her read a script. But they had to read the script while she was in an MRI machine, all right? And they had it turned on, and as she was reading, what they were watching was what parts of her brain were active, what parts of the brain were active versus what they expected to be active during normal speech. And what they saw in this person with dysregulated speech was a dysregulation in brain activity, all right, which is to me pretty interesting because they were able to identify very predictable ways that this person's central nervous system was not reacting and responding in response to reading the text, but then speaking it out, right? So they had, there's the baseline. They had her speak, they recorded it, they pulled her out of the machine, they did basically the equivalent of about an hour of treatment. They did use the more aggressive manual circumlaryngeal technique where they, you know, wanked the larynx around and then pulled it down in the place, and then they started getting her talking, which is, to me, the key piece. Can she hold that? And that's how it is to them. Once she was able to hold the voice, once she was able to speak in a clear way without them holding on to her here, they put her back in the MRI and they had her read the same script again. And what was pretty interesting, and again, you can go into the paper itself to learn all the specific areas of hyperfunction, poor function, the whole thing. But what they saw within that hour time was a very different brain. That as the woman spoke, her brain patterning was much, much closer to what they expect to see. To me, that paper, and then there was another one by Spangler that actually preceded this one in 2017. Those papers don't show that the problem's here and not here. What they do is show that possibly the problem as well as the solution in terms of the manual-therapy. The effect isn't just here, it's here. It's in the human being, and it's not just in the inferior constrictors, so to speak. And when we work with someone from a fascial perspective, the solution comes not because we change something at that micro level within their fascia, but we use the metaphor of fascial work to basically tap into all of these different things that we've talked about so far, and a few more that I'm going to cover yet. In the therapeutic environment, most of us have been taught from a clinician as expert model. I think that's the biomedical model. I think it's a lot of other models too, where the more education we have, the more training we have, the more experience we have, that we become better capable of determining what's wrong and determining what to do about it. I call that clinician as expert model. And it's basically at the root of most medical style interventions, and it certainly was the root of my my fascial training, if you will, but also most of the other continuing ed I took was about taking enough classes, pay enough money, spend enough time, get indoctrinated into the tribe far enough, and you will become an expert. Now I know that's ringing with cynicism, but that's how I view all of that past work of mine that I learned. It's helpful, but not all of it's helpful, okay? And contrast the clinician as expert model with the shared decision-making model. And shared decision-making is it's a newer concept. It's one that's becoming more common in medicine, in the therapeutics, but it really conflicts with the clinician as expert model. Because in my shared decision-making model of manual therapy, it's about saying, basically, I do know a lot. I've learned a lot. I've taught a lot. I've seen a lot of patients, some almost identical to you, but there are components that are missing from that expertise. And that's your own lived experience. That's your own values and preferences. That's your own beliefs on what might be useful and helpful. And a lot of patients just completely hand that over to us. Do what you think is best. I want to get better. I'll do whatever you say. And that is, well, it's common. It's also rather dangerous in a way if they totally give up power to us from a lot of different levels. Back in 2011, Diane Jacobs and Jason Silvernail, a physical therapist who was one of those original people on that Soma Simple conversation that I embarrassed myself on. Diane and Jason wrote a paper on, where is the title of it here? Basically, I don't have the title, but it's basically questioning the clinician as expert model. And I think the title of it was something to the effect of the operator versus interactor model. The operator is what they view as what I'm calling clinician as expert, right? The operator is us basically operating the machinery. We're pulling all the strings, we're pushing all the buttons, we're making all the decisions. And they're contrasting that with the interactor model, where the therapist becomes an interactor with the patient, and in making for a more democratic, if you will, type of relationship. Instead of being about skewed power, where we're up here and the patient's down here, they're promoting the concept of interaction, which brings them to more of an equal level. And that's what I teach and believe in my shared decision-making model as well, that the clinician as expert model, it has its place. We need to be an expert, but I'm enough of an expert to know I don't know everything. I'm enough of an expert to know that I don't know what you know and what you've lived and how you perceive things. Because people come in to see us every day and they say things that we think are wrong, or that's not the way the body works. That's not the way medicine works. That's not the way physiology works, et cetera, et cetera. We can keep going. But to that person, it's not that we want to lie to them and say, oh yeah, everything you say is right. But I've not lived the life of that person coming in to see me and telling me part of their story that doesn't quite resonate with me. They might tell me a mechanism of injury, something that doesn't quite seem like it makes sense, but doesn't have to make sense to me. it makes sense to them. That's what's important. So allowing that shared decision making include part of their process of accepting how they view themselves. All right. There's another concept that came to be more recently, and I believe in shared decision making. I believe in when someone comes to take a class from me, I tell them right off the bat that, especially when it's a speech pathologist who might have less touch-based training in college is on the job when it comes to manual therapy, that people come to my Foundations of Manual Therapy, Voice and Swallowing Disorders class thinking they're going to learn some really nifty, manual therapeutic interventions for specific disorders to target that tissue that's having the problem, right? I think that's a pretty good assumption that people come in with that mindset. And what I tell them is right off the bat, well, I do hope they learn some nifty things to do with their hands. What I really hope for them is that they learn the concept of shared decision making. The concept that we're using touch, just like Jerry said, as a means of communication, not as a means to fix a tissue. And I was recently introduced to Leah Halal, who is a professor at the University of Pittsburgh in their speech pathology department. And we had a conversation about some of her work, some of her writings, and she talks about metatherapy. Metatherapy, simply put, is the therapy that surrounds the therapy. She uses an example that there's certain, and I'm going to use one of the examples that she used, straw phonation, where you had the person blow or speak or make noise into a straw for its therapeutic benefits. And some of you, if you're watching this, you might already know what those are. Other people, it may sound very foreign, but the point is not to talk about that. It's just that the concept that that's an accepted intervention, a treatment strategy for voice clinicians. And what Leah in her papers talks about is the disconnect between the application of straw phonation by a new clinician and by someone who's been doing it for years. And why is it that the person doing it for years gets better outcomes with straw phonation than somebody who is new to it, when the technique is the same? You're having them do the same thing into that straw. It's not the technique that Leah says. It's what surrounds that technique, what surrounds that therapy that truly becomes the therapy. It's how we learn over the years, in the case of straw phonation, is how to create context, how to create meaning, how to create variability, etc., that creates a greater impact on somebody who's doing it for a while than somebody who just began to apply it. Now, I remember, again, here's my cynicism coming in, that if I was struggling at all with myofascial release, there was simply a simple solution to that. Well, you need to retake the class. You need to retake it and retake it until you get it. I retook a lot. I retook a lot as an instructor, too, as an assistant instructor. Did I learn more because I learned the techniques better? Or did I learn more because I learned the language that surrounds it? The metatherapy of myofascial release, and now I think it's more that latter. The concept of the metatherapy is exactly what we're doing in this work. It's less so about the thing that I'm doing right here to that fill in the blank of your tissue of your choice. It's that taking my pressure and asking my patient, is that causing you to become aware that we're doing something that seems relatable? Does this seem like it might be helpful or useful? And if not, what should I do differently? It's surrounding what seems like the treatment with the real treatment. We're seeing if we can get them engaged in a process where they are sharing decisions, that their input has value, and if they help me, I might help them even better. And to me, that's the metatherapy that surrounds this work. There's in a lot of the writings that I've done in the book, etc., there's a lot of other concepts that are relatable when it comes to explaining why myofascial release, why fascia work, why muscle work, why lymph work, why all the therapeutic interventions, including exercise, why they might be so much more than that small little piece that they're seen as. Right? But it's about, I think that's enough for today. You get the idea of what we're talking about here. At the end of this, I'm going to link that page from my website where you can download.